my task today is to brief about narrow complex tachycardia management in the emergency department. My name is Dr. Xiao. Thank you so much. My task is quite difficult because in order to manage the narrow complex tachycardia, I have to make everybody happy, all right, and not to worry about this. So by the definition of narrow complex tachycardia, as very obvious, very different from bradycardia. So whenever you have the heart rate of more than 100 and the QRS complex is narrow, means that the QRS complex is actually lesser. I mean, is in the ECG strips is less than 3 small boxes or less than 0.12 seconds. So it will fall into narrow complex tachycardia. Okay, so I would like to ask the participants or the audience to. Okay, all right. So this is my first question that I would like to ask all of you. If you're able to look at the screen. So the first question that I would like to let all of you to try on is when you manage the narrow complex tachycardia, whenever the hemodynamic unstable, of course we know it's going to do a cardioversion. But if let's say the vital signs are okay, and what will be your next step? All right, so we have 4 answers. A, cardioversion. B, adenosine. IV adenosine. C is carotid massage, and D is IV amiodarone. Can we launch the poll now? All of you may answer the question. All right. Okay, so thank you so much for your response. Okay, we see the answer is carotid massage. Thank you so much. It is correct. So if I'm given the chance, I might choose IV adenosine because previously I will always use adenosine instead of carotid massage. All right. So very good. So most of you got correct answer. So this algorithm is actually taken from ESC guidelines 2019, the management of SVT. So before we give IV adenosine, always remember we have to do the vagal maneuvers. Of course, not only carotid massage, some other vagal maneuvers also we can use. But bear in mind that there's something that is very important before you proceed to the carotid massage. Make sure not to massage both sides at the same time, because when the patient comes into the emergency department, everybody will jump into the patient, and then you start doing this puncture, putting a cannula. So we may help each other to massage both sides of the carotids. It will cause hypoperfusion of the brain. The patient might collapse. All right. Another thing is before you apply the carotid massage, make sure there's no bruit over the place that you're going to massage, because once you if there's a bruit, it means that there is a stenosis over the particular vessels. So if you massage it, you might cause the patient to have stroke. All right, so bear in mind these 2 things. All right, so let's move on. So after we give IV adenosine, there's in that particular guidelines also it tells you after you give IV adenosine, there will be a response. And what are the diagnoses? So you can see there's no effect after you give IV adenosine, or gradual slowing and then re-accelerated, and then or sudden termination, or even a persistent tachycardia. So what does it all mean? So hopefully by looking at the next slides, hopefully it will give you more clues. So for example, if you in ED seeing the strips, on the screen, so roughly it is a narrow complex tachycardia. I'm sure all of you agree with me. Then do you see a P wave? Likely not. All right. So we decide to give IV adenosine. So what happened? Okay. Oops, sorry. Hold on, yeah. Okay. All right. So we give IV adenosine, and you see like quite a scary pause here, and then it resumes again to the sinus. So what is your diagnosis? So we run one more time. You give IV adenosine here. So what happened here is you see like a flat line here, like and then there's one P wave here. It's actually is a SA node. It actually kind of recovers, and then because the adenosine is blocks the AV node, and eventually the AV node recovers and then start to have the resumes back to the normal sinus rhythm. So if you're looking at the response of adenosine based on the table just now, if you see a sudden termination, so most likely it is a AVNRT or AVRT. Don't worry about the last two. It's quite a rare disease. So I would like to highlight on this adenosine effect on the ECG is because it will be very important for us to know the underlying cause. All right, and the adenosine will actually stop those tachycardia, which is the re-entry. It depends on the AV node. It means that the tachycardia will need to go through the AV node. So adenosine will block this kind of this kind of tachycardia and will show you the on the ECG strips, right? So the second example, okay, so if you see this is still a narrow complex tachycardia. All right, so you give IV adenosine here, and you can see some of the small bump, and then there's a bronchiolitis complex, then it resumes again. So what is your diagnosis? I'll give you some time to look at the strips. Right, there's no pole. So let us look at these strips again. So you give IV adenosine here, you see a lot of P wave here, all right? Then you see we say PVC, or this is a ventricular escape beats, all right? Then the tachycardia resumes again. So what does it mean? So based on the table just now, after you give IV adenosine, so it will have the transient block. But if you see all this block, it actually tell us that the underlying problems, and this is actually is a atrial tachycardia, because you see a lot of P wave here. All right, if this P wave is a little bit more big bump, most likely it will be a flutter. All right. Okay, so this table, I'll just show you the table just now. The response, this response are telling us the adenosine, how the adenosine works. All right, and what are the underlying problems. Okay, so if let's say after you give IV adenosine, there's no effect, so it might be inadequate dose. So or of course a high subtle VT as well. So remember how to give IV adenosine using the neckline or the anticubital line, large ball, flush after you give a 6 milligram, 12 milligram, 12 milligram up to maximum is 612. All right. So if let's say IV adenosine fails, so what are you going to do? So just be familiar with IV verapamil or IV piltazam or IV beta blocker. I've personally never used IV beta blocker in emergency or even in ward, but I think IV piltazam is available in a medical ward. I'm not too sure about the emergency, so just familiar with these few drugs. If let's say you are going to if the adenosine fails, all right. So if all this fail, go to synchronized cardioversion, right? So just now I show you the strips that after we give IV adenosine, then after that there are the response that we can actually see. Does it really matters? It really matters to those receiving end, especially the electrophysiologists, because the transition of IV adenosine will give us the clue what are the underlying causes. And the ECG during the tachycardia, especially like a P wave and the ventricle, the V and the A relationship will give us more clues. All right. Another thing is if you have the sinus rhythm ECG and you have the tachycardia ECG, so we can always compare. If both are identical, it will be most likely it will be SVT, and if both of the tachy ECG and the sinus ECG is not the same, most likely it's a VT. All right, so always remember to attach the tachy ECG, the SVT ECG, and the sinus rhythm ECG in the referral letters. Like for example, I want to show you this. This ECG basically very obvious. It will be a narrow complex tachycardia. All right, so heart rate is 150. After we give IV adenosine, boom, it becomes sinus rhythm. So if we compare these two ECGs, the left side of these strips it will be a tachy ECG, and you can see some inverted P here. All right, so the QRS complex of the tachycardia and the sinus rhythm basically is almost the same. All right, you look at this. Okay, I hope you agree with me. So it will be this will be a SVT. Whereas this ECG, very lucky enough that we can see sinus rhythm ECG, all right, and the broad complex QRS the sinus rhythm QRS and the broad complex QRS on the same strips. All right, so this pointing towards this patient most likely to have a VT. All right, so the tachy ECG and the sinus rhythm ECG are so important for us to determine what are the underlying causes. Okay, another patient that I want to show you is 25 years old patient, basically admitted to for ASD closure, and fortunate or unfortunate enough, the nurse noticed the patient become very achy in the ward while waiting for the ASD closure the next day. So the nurse managed to capture this, and can you see this? There's a delta wave. So this kind of ECG, which has never happened before, and the patient never complained of palpitation. So lucky enough that we catch this ECG, that we ablate first before we close the ASD. If not, that will be very very tough to go through the fossa ovalis to puncture to the other side. All right. So this patient is a pre-excitation. Means that this accessory pathway. There's an accessory pathway, right? So by talking about this, so I think let us do some exercise based on the algorithm just now. All right. So we have a 30 years old patient, male patient, gentleman, intermittent palpitations. So looking at this, can we have the poll? So looking at the ECG, what will be your next step? All right, cardioversion, adenosine, echo, deltaism, or you need more info? Probably we just make it like about 15-20 seconds. So all of us just quickly, if you don't know the answer, just choose C. Okay, all right. Okay, so you can see most of us half of us choose adenosine. The next will be need more info. Yes, I think we need more info because we don't know whether this is stable or unstable. So back on the algorithm again. So you see, we don't know whether is it stable or not stable. So this patient basically is stable, and then we do the vagal maneuver. If ineffective, we give IV adenosine. All right. So after we got to know, look at the blood pressure, look at the patient, then only you decide to give IV adenosine. So after IV adenosine, you look at the ECG again. There's a P wave here, very nice P wave. So of course, based on the ECG just now, and this one, of course, is identical. This is SVT, and we based on the table just now, this is either is an AVNRT or AVRT. All right, so we did a EPS for him. Is an AVNRT, a typical type. So we did a treatment for ablation, and it's done. Okay, so next question. The second question: 20 years old pregnant lady, palpitation in the 3rd trimester, came to emergency department, vital sign unstable. All right, so what is your next step? Okay, can we have the poll now? All right. So the first answer is the first choice is cardioversion, adenosine, echo, or dildanism. Let's choose. If you don't know the answer, just choose C. Yeah. All right. Look at the ECG, and I give you some more time for this because this pregnant lady have to be cautious. All right. Can we have the answer? Okay, adenosine. Some of you choose cardioversion or echo. All right. So based on the algorithm, so if the vital sign is okay, we do vagal maneuver. Then one thing that I would like to highlight, whether IV adenosine is it safe enough in pregnant lady for this case. Okay, so later on we'll talk about IV adenosine. So let's look at the ECG again. Actually, adenosine is right. Echocardiography also correct. The reason behind, because if you give IV adenosine, you can actually unmask what is the underlying cause. Another thing is, if you notice, the QRS complex of each alternate QRS complex is actually one small, another one is bigger, one small, another one is bigger. So, but if let's say this one is we call electrical alternance, so pointing towards most likely the patient might have a pericardial effusion or even tamponade, but the patient seems like quite stable, quite comfortable. If there's no pericardial effusion, so what's next? All right, so if you're looking at this, I've just zoom in the ECG for you. All right, so the first thing I think we should always rule out pericardial effusion or tamponade. All right, the second thing is, if let's say there's no effusion, it will be called a pseudo-electrical alternance, or sometimes you call it amplitude alternance. So it is a type of SVT. So with the higher prevalence of accessory pathway in the, not only in the pregnant lady, but in in other patients or other types of patients as well. All right. So what is that? Do the echo. If there's none of the pericardial effusion, think of this differential diagnosis as well. All right. So cardioversion, is it safe during pregnancy? Yes, it is safe. And if it's unstable, always there's a first choice, right? I think this one just quickly. So have you ever wondered why sometimes you want to synchronize, sometimes you want to non-synchronize cardioversion? All right, so because we just want to avoid, if let's say you can see a QRS complex, you can see a very nice T wave there. So we will use the synchronize, because we don't want to hit the RNT phenomenon cause ventricular fibrillations. So if you meet the SVT, flutter, AF, so we always synchronize the cardioversion. And if let's say it's a pulses VF, VT, you don't know where to hit, so we use a non-synchronized. All right, so drug of choice during pregnancy, adenosine, digoxin, beta blocker, basically quite safe, except atenolol because higher prevalence of getting IUGR. Verapamil also quite safe. All right, of course, diltiazem, amiodarone is definitely not, is definitely no in in pregnancy, unless very tough case, then there's a different story. Okay, so for drug of choice of non-pregnant patients, all these drugs have to be cautious, especially like for example, adenosine and beta blocker. Just bear in mind that avoid in COPD or asthma patient. I've seen a patient that someone was given adenosine, to treat the SVT for COPD patient. SVT resolved, but the patient intubated and sent to ICU. So settle one problem cause another problem. So remember, familiar with your drugs, do no harm. Yeah? And like for example, digoxin, cautious with end-stage renal failure patient. Verapamil, diltiazem, cautious with heart failure patient. All right. Amiodarone, avoid in thyroid disease. Okay. Okay, this one I just want to show you. Make sure you, before you give IV and adenosine, make sure there's no COPD or asthma. Don't give to those patients. It will be very difficult to answer to the family members. All right, I think I'm exceeding the time. Can you give me another 5 minutes? All right, so just a quick one to go through the another two case. So 85 years old gentleman. This one is the third case. 85 years old gentleman, history of asthma and AF. Patient came in chest pain, dyspnea, BP is borderline. So what is your next step? So I think I don't want to start the poll because we really running out of time. So you just look at the ECG and just think of what do you think about this ECG? All right. So what are you going to do? Cardioversion, adenosine, echo, diltiazem. Okay, quick one. So again, vital sign of borderline. Do you want to really do a vagal maneuver for him? Adenosine. Once you give adenosine, maybe the BP will crash. All right. How about other drugs? All right. So looking at the ECG again, because this one I actually taken from circulation. So the ECG challenge. So the author, they decided to do echocardiography because they look at this the very widespread ST depression. You can notice that, and the ECG basically the heart rate is about 100. So echo basically about 45 to 50, and very widespread ST depressions, and the AVR is also elevated, widespread ST depression. So they did perform angiogram for him, and there's no stenosis and CAD. So what is this about widespread ST depression? So the answer is basically is one of the possible diagnosis is digoxin toxicity, because this patient also had a worsening renal function. So this is we call a reverse tick. It's like Nike, you know. The Nike is the you reverse the Nike sign, or you call a reverse tick sign, or Salvador Dali Dali mustache sign. Okay, this one. So eventually, I think the author decided to dialyze the patient. All right. So because the patient had digoxin toxicity. So I want to highlight about this case is not all the patients will narrow complex tachycardia will settle with adenosine vagal maneuver or beta blocker, calcium channel blocker. Always think out of box. All right. Think of some other things. All right. Drug history, history taking are all always crucial. Do not only treat the ECG alone. The fourth case, all right, 25 years old patient with sudden onset palpitation. This one. What is your next step? Not really need to launch the poll, but just look at this ECG. So I think this one I taken from a Jack case report. So look very bizarre. Some is narrow, some is broad. So before we decided to do anything for him, the patient became hypotensive, diaphoretic, and then synchronized cardioversion was performed. So after that, this is the ECG strips. What do you think about this? So if you can see this delta wave here, and if you notice just now the ECG was actually irregular. So the answer is pre-excitation AF. So this kind of patient is very tough to manage I think it will be very tough to manage because for one thing, if unstable, easy cardioversion will be very straightforward. But if those are stable patients, those drugs that like ebutalide, procainamide, propafenone, and flecainide are not always available in emergency department. So I think this kind of patient, I want to highlight that always discuss with the cardiologist to what is the best way to manage this patient. All right, because beta blocker, calcium channel blocker, digoxin, amiodarone, all these drugs are not really suggestive, not really safe, or sometimes even we need to avoid, because once you give these drugs, you might cause ventricular fibrillation. All right, so pre-excitation AF is one of the diagnoses that a little bit tough for us to manage in the emergency department. The last one, do we still have time? Just a quick one. the last case, a 40 years old gentleman, intermittent palpitation for 3 months. So what is your diagnosis? Not necessarily launch the poll, but this one I just want to show you another very rare disease. AF, sinus tachy with PAC, ABNRT, with Parkinson White. Okay, so if you notice, this one I have taken from one of the I think from the circulations. So if you notice, this one there's 1P, and then there's 1 QRS here, and 1P, and 1 QRS, 2 QRS. So this one, sometimes we call it dual AV nodal non-reentrant tachycardia. Don't worry so much about the name. To make it simple, sometimes we call it 1P, 2Q. So if you see 1P here, there's a 2 QRS complex. 1P here, and then 2 QRS followed with 2 QRS complex. All right, can you see that? Okay, so what does it mean is one sinus beat conduct to the fast pathway and conduct to the slow pathway. All right, and so on and so forth. So of course there are some other is only 1P and 1 QRS complex. So this kind of patient basically is not fall into any kind of, it's not ABNRT, not ABRT, because it's all going through the AV node and conducting down to the ventricles and causing the tachycardia. So the treatment for this patient is ablation of the slow pathway. So lastly, take home message: always look for the clue during or after administration of adenosine. Always attach the tachycardia ECG and the sinus rhythm ECG in the referral letters to give us more information. What is the initiation, the termination, or what is the clue? I mean, what the